how to approach slides and how dermatopathology actually evolved over the last century or so, and how a system for pattern analysis was developed by which it made it easier to diagnose or at least consider differential diagnosis for inflammatory skin diseases. A lot of skin biopsies that we get, at least in India, are inflammatory skin diseases. We don't get so much of tumors. So inflammatory skin diseases are difficult to diagnose because they have very subtle findings and they do need a lot of clinical correlation. So both go hand in hand. So let's talk about the historical aspects and evolution of a system for diagnosis of inflammatory skin disease. So how did it evolve? It started off as descriptive dermatopathology. So because clinicians or dermatologists were the first dermapaths, they used to see the patient. This all started after Virchow started surgical pathology in the 1830s and 40s. So by 1850s, the clinicians were taking their own biopsies, looking at it under the microscope and reporting the findings, and then correlating the clinical findings with the histological findings. And that's how diseases were being described. Because in the 19th century, diseases were not really very clear as they are today. So it began in Europe in the middle of the 19th century. Germany, France, and Austria, and of course, London in the UK were the main centers. So diseases were first clinically defined, and then the histology was described, and that is how you got a composite description of diseases. This, of course, was the father of surgical pathology. So in Germany, you have big names, and all these names, Unna, Lewandowski, Yadason, you may not be familiar with them, but all dermatologists are familiar with them. These were dermatologists. There were a lot of eponymous diseases named after them. And they were also the first dermapaths because they used to do biopsies of their patients and describe the diseases. In Paris, it was Darrier. You've heard of Darrier's disease, I suppose. Besnier, Brock, etc. In Vienna, it was Hebra and Kaposi. You must be familiar with Kaposi sarcoma. This was Hebra. So descriptive dermatopathology ruled the roost, and several textbooks appeared on dermatopathology in the first. Is this coming in the way?
It's fine. It's fine.
Walter Lever's Histopathology of the Skin. You may be familiar with this because this was one of the finest textbooks of dermatopathology and embodies the acme of descriptive dermatopathology. The first edition came out in 1949. And descriptive dermatopathology was based on several unrelated morphological findings, and histological diagnosis was usually possible only if the clinical diagnosis was known. So this was the problem, that generally you knew the clinical diagnosis, you looked up the slide, and you tried to match findings so that you corroborated the clinical diagnosis. So if you were given the slide to see without any clinical diagnosis, it would become difficult to make a diagnosis. This was Walter Lever, and this is a very famous textbook of his. This was the 6th edition. He died in 92, and then it became a multi-author textbook. By the middle of the 20th century, the focus of dermatology had shifted across the Atlantic to the United States. A lot of German dermatologists, many of them were Jews, so they had to leave Nazi Germany and they sought refuge in the United States. And they were the ones who really contributed to dermatopathology. Workloads increased, and dermatopathologists, why is this coming up? Workload. Why is this annotation request coming all the time?
I think, yeah. We request all the students, please do not send annotation requests to teacher. And Dr. Joshi, sorry for this interruption. You can reject it. Don't accept that. That's all.
Decline it, sir.
Decline it.
Workloads increased. I mean, the US had tremendous workloads, and dermatopathologists were reporting on slides from patients they would never see clinically. So there was a need for pathology-based diagnosis was felt and led to diagnosis based on purely morphological findings with emphasis on the pattern analysis. Specific diagnoses were possible with the help of algorithms derived from purely morphological findings. Why is this getting stuck? Hermann Pincus, he was actually from Germany. He started describing the patterns. So he talked about the psoriasiform tissue reaction, lichenoid tissue reaction, eczematous tissue reaction. So this was in the 50s and the 60s, 1950s. But it was in New York and Philadelphia that this person, Bernie Ackerman, he is my mentor. I was lucky to do a fellowship under him. A phenomenal person. And in his first edition of this book, which he called the Gold Book, which came out in 1978, he espoused pattern of inflammatory diseases and diagnosis of them based on pattern analysis. Now, this was predicated on the following. One is that inflammatory diseases develop due to migration of inflammatory cells from the circulation into the affected tissues. The arrangement of these cells within the tissue is fairly specific and repeatable for all individual diseases. These patterns, therefore, can be used by a histopathologists to diagnose groups of diseases with similar findings. The diagnosis can be made more specific by identifying individual characteristics of the various diseases in that group, similar to biology, where every organism is identified first by the genus, then family, then the species, etc. So you can form a small group of differential diagnoses and try to come to a specific diagnosis, and then, of course, correlate with the clinical findings. So if you look at the blood supply of the skin, you have two major plexuses. You have the deep plexus, which is at the junction of the deep dermis and the subcutis, and then you have the superficial or the subpapillary plexus, which is at the junction of the papillary and the reticular dermis. And you have these blood vessels from the superficial plexus which go near the surface of the skin of the epidermis in the form of capillaries and postcapillary venues. So depending on where the inflammatory cells are situated, you could derive various patterns. So the patterns of inflammation that Ackermann first described in 1978 were the following: superficial and superficial perivascular dermatitis, superficial and deep perivascular dermatitis, nodular and diffuse, intraepidermal vesicular and pustular, subepidermal vesicular, vasculitis, paniculitis, fibrosing dermatitis, and folliculitis. So this generally summed up most of the inflammatory diseases. So superficial perivascular, as the name suggests, the inflammation is restricted mainly to the upper part of the dermis around the blood vessels of the superficial plexus. Superficial and deep would mean superficial and deep involvement. So a different group of diseases show this pattern. Now, just to illustrate the example of superficial perivascular dermatitis, you may have no epidermal involvement, and you would have an infiltrate restricted to around and about the superficial plexus of blood vessels, or you might get a prominent epidermal change which predominates, and then you can have a pattern based on the epidermal changes, which would include spongiotic, psoriasiform, interface, ballooning, etc. Then you look at the nature of the inflammatory infiltrate, whether there are lymphocytes, eosinophils, neutrophils, mast cells, etc. And each one of them would generate a differential diagnosis. So, for example, if you have superficial perivascular dermatitis, perivascular only with lymphocytes, no epidermal changes, you could think of the following conditions: pityriasis versicolor or tinea, in which case you look for hyphae and spores in the stratum corneum, and if they are present, you can make a definitive diagnosis. Vitiligo, where there are no melanocytes and there is absent melanin in the basal layer. Schamberg's disease, where you have extravasated RBCs and hemosiderin deposits, or you may have no specific changes, in which you would start thinking of a mild morbilliform viral rash, a drug rash, or a condition called erythema annularis centrifugal. So that way you can have smaller group of diseases which are easier to diagnose. Then you can get superficial and interstitial, when the cells start going in between in the dermis. So if you have lymphocytes, you have Schamberg's disease, or what is known as pigmented purpura. If you have eosinophils, you consider bullous diseases like bullous pemphigoid, insect bites. PUPPP is the polymorphous eruption of pregnancy. If you have neutrophils, there is a differential diagnosis which includes lupus erythematosus, erythema marginatum, early leukocytoclastic vasculitis, dermatitis herpetiformis, etc. If you have a combination of neutrophils and eosinophils, you think of urticaria. If there are melanophages, you think of macular amyloidosis. If there are sidrophages, you think of stasis changes. And if there are mast cells, you think of urticaria pigmentosa. Then you have spongiotic dermatitis. That is when the epidermis shows spongiosis. And this is how you differentiate them. If you have mainly lymphocytes, you have the so-called eczematous group. If you have eosinophils, you have a different group. You have bullous pemphigoid, insect bites, etc. Of course, there could be overlaps between the two. And this is an artificial morphological classification. Diseases, as they always say, don't read textbooks. So you always have overlaps, you have exceptions, but those are rare. So if you follow this, generally, most of the times you can come to some credible differential diagnosis. Then you can have combination of patterns: spongiotic psoriasiform, spongiotic lichenoid, spongiotic psoriasiform lichenoid. If you see, the differential diagnosis keeps changing. So if you can recognize your primary patterns, you could think of all these differential diagnoses. Psoriasiform, for example, if you have only psoriasiform, these are the differential diagnoses. If you have psoriasiform lichenoid, you have a totally different set of differential diagnoses. So to illustrate, let's look at this slide. So epidermis is more or less normal. So at first, at low power, and these patterns are best seen at low power. So you always start with scanner view, the primary pattern, then go to higher power to look at the nature of the cells or any other specific findings that you can look at, and then put it together. So here, if you see the primary pattern here would be perivascular. If you see, there is mainly superficial and deep, or superficial and mid perivascular infiltrates, which seem to be lymphocytes. They are bluish in color. At a higher power, you notice that yes, there are lymphocytes around the blood vessels, but the interstitium too has cells. So you have cells which seem to be interstitially scattered. So this pattern would be superficial and deep perivascular and interstitial dermatitis. You go to still higher power, and you see that there are a lot of eosinophils. Here, plenty of eosinophils which are scattered. So now you can come to a differential diagnosis of conditions like insect bite reactions, drug reactions, bullous pemphigoid. Based on this pattern here would be superficial and deep, perivascular and interstitial with a lot of eosinophils. So the differential here would be urticaria and insect bite reaction. Insect bite is more likely because the number of eosinophils is very high. Urticaria is less likely because neutrophils usually also accompany eosinophils in urticaria. Then, of course, once you come to this differential, you look at the clinical picture and you could come to a final diagnosis. Now here, if you see, there are epidermal changes. So you have epidermal changes here, superficial perivascular, and this is ballooning, where you have individual keratinocytes which are ballooned. Ballooning is because of intracellular edema. So the entire epidermis is hyperplastic. The individual cells are ballooned and have actually formed vesicles within the epidermis. These are the ballooned keratinocytes. You have a lot of eosinophils here. Eosinophils again. These are the balloon keratinocytes. You can see them pale in appearance. And here the keratinocytes have been destroyed or disintegrated to form intraepidermal vesicles. The dermis has a dense lymphocytic infiltrate with innumerable eosinophils. So this again is an insect bite reaction. Now, if you notice, there are two different patterns here. One was ballooning and one was superficial and deep perivascular and interstitial. Both of them can be seen in insect bites. So this is one thing that happens, that the same disease might have multiple patterns and the same pattern may be shown by different diseases. Another example of ballooning with acantholytic cells, which has formed intraepidermal vesicles. So this is herpes infection. Then you get spongiosis. Spongiosis, unlike ballooning, which is intraepidermal edema, is interepidermal edema, intercellular edema. So that appears as pale areas. So this is spongiosis. So you see that the keratinocytes are separated from one another because of edema. And what you can see here are the intercellular bridges, which are the desmosomes. And if the spongiosis increases, this would form a vesicle at a later stage. So this is mild to moderate spongiosis. The other thing is with spongiosis, you can get inflammatory cells, usually lymphocytes. So this is known as exocytosis of lymphocytes. A few lymphocytes are seen within the epidermis. Otherwise, normally you don't see lymphocytes within the epidermis. So spongiotic dermatitis. So that would be one pattern. Then psoriasiform. So this is psoriasiform pattern, where you have elongated rete ridges. And the psoriasiform pattern can have many diseases, or many diseases can give rise to the same pattern. The prototype, of course, is psoriasis, but pityriasis rubra pilaris, Ilven, which is inflammatory verrucous nevus, prurigo nodularis, long-standing, as well as mycosis fungoides and secondary syphilis. So if you notice, this group of diseases has varied etiology. You have a malignancy, you have an infection, you have autoimmune diseases, you have frictional diseases. So etiologically, different diseases can give the same pattern. So what we are concerned with morphologically, when we look at it under the microscope, we are not bothered about the etiology first. We are first bothered about the morphology and grouping it into a particular pattern, and then you can go in and discuss the various differential diagnoses that would occur. Then you have interface, where you have the dermoepidermal junction, which is affected. So it could be, that is basal cell vacuolization. So this is known as vacuolar interface dermatitis. Example of that would be lupus erythematosus. If you see here, you have a lot of basal cell vacuolization, flat epidermis, a thickened papillary dermis with this brown melanophages indicating damage to the dermoepidermal junction, and a perivascular lymphocytic infiltrate. So you have basal cell vacuolization, and this can give rise to individually necrotic or apoptotic keratinocytes. Examples here would be lupus erythematosus, erythema multiforme, pityriasis lichenoides chronica, etc. And you can also get a lichenoid infiltrate in addition to the basal cell vacuolization. Here, of course, the prototype is lichen planus, where you have a band-like infiltrate, as well as interface changes which affect the dermoepidermal junction. So lichen planus, pleva, graft versus host disease would come under this lichenoid interface group of diseases. Then you have nodular. So perivascular, where it becomes extensive or it becomes dense, you start seeing nodules of cells which are discrete from one another. So depending on which cells there are. So if you have, say, lymphocytes, this is a pseudolymphoma with a small germinal center in the middle. Or you can get granulomas. So granulomas is a subset of nodular dermatitis. You get well circumscribed nodules of histiocytes, epithelioid cells, giant cells, accompanied by lymphocytes. The intervening dermis is normal. So, and here the granulomas are seen to preferentially involve the adnexal structures. So this is tuberculoid leprosy. You can see the giant cells here. So epithelioid cells, giant cells, well circumscribed, involving the hair follicles, involving nerves, involving eccrine structures. So this is leprosy. So nodular dermatitis, subset would be granulomatous dermatitis, and then depending on the specific involvement of adnexal structures, you make a diagnosis of tuberculoid leprosy. Again, nodular. But if you look at the components of this, these are histiocytes, and look at the color. This has an amphophilic cytoplasm. The previous one had more pink. These were epithelioid cells. These are histiocytes with amphophilic cytoplasm. If you were to stain this with 5 stains, these would be full of acid fast bacilli. So this is again nodular dermatitis, histiocytic granulomas with specific involvement of adnexal structures. You see eccrine structures involved here. So this is borderline lepromatous or lepromatous leprosy. So you had tuberculoid Hansen's as the first slide, and you had BL or LL Hansen's as the second slide. Then you have diffuse, where the entire dermis is involved. Example is this. The entire reticular dermis is infiltrated by cells, and these are the cells. They are large atypical cells. Leukemia cutis, for example. So unlike a lymphoma, which will be a nodular dermatitis most of the times, where you can get discrete nodules, leukemia in the skin might present as a diffuse infiltrate of atypical cells. Then the next pattern is intraepidermal vesicular pemphigus. So superficial flat blister within the epidermis, lined by a single row of basal cells, the so-called tombstone appearance. So this is intraepidermal vesicular. The differential here is pemphigus vulgaris. You get also involvement of the acrine ducts. You get acantholytic cells. So this is pemphigus vulgaris. This is called tombstoning because you get a single row of basal cells. So if you have acantholysis, the differential is pemphigus. If you have spongiosis with intraepidermal blister, it could be acute vesicular contact dermatitis. And if you have ballooning, it could be herpes. We saw one case of intraepidermal blister because of ballooning and acantholytic cells because of herpes. Then you have subepidermal blister. So here, if you see, unlike the previous slide, the blister is formed beneath the epidermis. The entire epidermis forms the roof of this blister. And within the blister and in the dermis, you see, apart from lymphocytes, you see eosinophils and neutrophils. So this is bullous pemphigoid, perivascular lymphocytes and scattered eosinophils. So subepidermal blister with eosinophils, the diagnosis is bullous pemphigoid. So if you have subepidermal blistering diseases, predominantly eosinophils, the pemphigoid group of diseases, with neutrophils, you have a different differential. So dermatitis herpetiformis, SLE, that is bullous SLE, linear IgA dermatosis, epidermolysis bullosa acquisita, and post-inflammatory, where you do not have inflammatory cells, you just have subepidermal blisters. You think of the congenital or the genetic form of epidermolysis bullosa and porphyrias. Then you have vasculocentric infiltrates with damage to the blood vessels, vasculitis. If you see here in the epidermis, most of the blood vessels seem to be involved, and they are made prominent because they have pink fibrin deposits in their walls. And you also have an interstitially scattered infiltrate, which has neutrophils and neutrophilic nuclear dust. What you see here is leukocytoplasia, the breaking up of the neutrophilic nuclei. So this is very typical of leukocytoclastic vasculitis. So it's primarily a vasculocentric pattern where you have damage to the blood vessel walls, fibrin deposits in vessel walls, and a dermal infiltrate which is interstitial of neutrophils and neutrophilic nuclear dust, which is also known as leukocytoplasia, and therefore the name leukocytoplastic vasculitis. Vasculitis can be classified based on which vessel is involved, whether it's a small vessel, medium vessel, large vessel, because the tissue response will be different, the diseases will be different. In the skin, we mainly see small vessel leukocytoplastic vasculitis, which affects small post-capillary venules. You have fibrin deposits, you have perivascular and interstitial infiltrate of neutrophils and neutrophilic nuclear dust, which is leukocytoplasia, and extravasated RBP. The common diseases here would be henoch line purpura and small vessel vasculitis because of other causes, which could include infections, malignancies, lupus erythematosus, drugs, etc. Then, when you get involvement of the subcutaneous fat, what is called paniculitis, that is of two types. One is the septal paniculitis, that is the fat lobules themselves are spared, but the main damage or the main effect is seen in the subcutaneous fat septae, fibrous septae. The prototype of this is erythema nodosum. So if you see, by and large, the fat lobules are not affected, but the fibrous septae, which separate these lobules, are markedly thickened, edematous, and infiltrated. You can even get small collections of histiocytes and small granulomas here. So this is typical of septal paniculitis, which is seen as its prototype in erythema nodosum. You can see small collections of histiocytes, giant cells. So septal paniculitis is erythema nodosum. And the reverse of that, that is when the fat lobules get involved, that is lobular paniculitis. And that has a whole series of differential diagnoses, depending on the sort of cells which damage, the type of damage that occurs. So this is lobular paniculitis. The entire lobule is involved. You get granulomas here. You can have a differential diagnosis of erythema induratum, which very often is associated with TB. Lupus paniculitis. A close differential of lupus paniculitis would be subcutaneous paniculitis like T-cell lymphoma. Pancreatic paniculitis, which is enzymatic. And scleroderma neonatum, which is a very highly specific disease of neonates. Then you have fibrosing dermatitis. So you need to know the difference between fibrosis and sclerosis, because sclerosis is typically seen in morphia and lichen sclerosis, whereas fibrosis would be seen in scars, keloids, chronic lymphedema, and dermatofibroma. So this is fibrosis with a little bit of lymphedema. You have thickened dermal collagen, and through that you see a lot of these blood vessels which go vertically upwards. So this is typical for a scar, and the pale nature of this suggests that this is because of lymphedema. You can see the intercellular edema over here. These are the blood vessels which are thickened and they are vertically oriented. Normally, you don't see these blood vessels in the skin, but when you have a scar, they become very prominent. On the other hand, this is hyalinized sclerosis. So this is typical lichen sclerosis, where you get hyalinization of the upper dermis and a band-like infiltrate of lymphocytes at its base. So there's a difference between fibrosis and sclerosis. If you see sclerosis, there's a whole group of diseases which is different from that what you see in fibrosis. So this is sclerotic collagen, acellular generally, absence of adnexal structures, and this is typical of lichen sclerosis. Then you get folliculitis and perifolliculitis. So pattern analysis with algorithmic diagnosis of inflammatory diseases, basically you get combination of patterns. Then as time went by, different authors started contributing their own work. So they started talking about tissue reaction patterns and recognition of specific histological findings in different diseases for a specific diagnosis. In 1996, Ackerman had his second edition. This was a totally different textbook called as a silver book. At the same time, in 97, David Weeder, he's a very respected dermatopathologist from Australia. He published his book, and this is now become a very standard reference book in dermatopathology. Now he's twisted it a little bit. He spoke about the main patterns being superficial perivascular, superficial and deep, perifolliculitis and panniculitis. And then he spoke about spongiotic, psoriasiform, lichenoid, vesiculobullous, granulomatous, vasculopathic. So primarily the same thing, slightly twisted. So how do we do, or how does one follow these patterns? So first you recognize the basic pattern or tissue reaction. So whether it's spongiotic, intraepidermal, vesicular, etc. Use of secondary pattern if present. For example, granulomatous inflammation, which is a subset of nodular inflammation. Specific findings, for example, thickened basement membrane in DLE, nerve destruction in leprosy, etc. When you find these, it becomes easier to give a more specific diagnosis. Sometimes you do not have specific findings, in which case you leave it at the pattern. You can generate a group of differential diagnosis, and then you go back to the clinician, look at the clinical findings, look at the clinical differential diagnosis, and try to come to the best fit that is possible. So just to share an example, this is from Ackerman's book. The primary pattern is perivascular dermatitis, lymphocytes mainly. Also epidermal changes of spongiosis. So in this case, what would the differential diagnosis be? So if you have slight acanthosis with small mounds of parakeratosis and focal spongiosis, then the differential diagnosis could be either pityriasis rosea or erythema annularis centrifuge. If you have uneven psoriasiform acanthosis with scale crusts and spongiosis, you could be dealing with eczema. Or if you have a follicular hyperplasia and you have scale crust lip of the follicular infundibula, it's seborrheic dermatitis. So that's how you go: the primary pattern, secondary pattern, and specific findings. Another example where you have psoriasiform acanthosis. So you have dilated tortuous capillaries in dermal papillae, thin rete ridges, etc. Psoriasis. Pityriasis rubra pilaris, where you have the rete ridges are not uniform. You have a well-formed granular layer. And lichen simplex chronicus. So this is how you go using the pattern. In the lichenoid arrangement. This was the third edition, 2005, which was probably a combination. Again, more or less the same patterns, slight twisting. It's like your lymphoma classification, they keep changing. Same way he tried to change it, but more or less they remain the same. Now, what are the limitations? Whenever you do something, whenever you introduce some, some method, there will always be limitations. So it's important to understand it. And the limitations of pattern analysis are that many diverse unrelated diseases show similar patterns. So psoriasis, mycosis fungoides, secondary syphilis, all fall under the psoriasiform pattern. The same disease at various stages of its development can show different patterns. So psoriasis to begin with can be perivascular, on the hands and feet can be spongiotic. In the typical form, it is psoriasiform, but it can also be pustular. So there are different patterns that the same disease might show. And more than one pattern may be present in the same section, causing difficulty in assigning the disease to a particular pattern. But whatever it may be, if you follow the various patterns, chances are that you would come to the specific diagnosis one way or the other. It's like having 2 or 3 different paths to the summit. Whichever path you take, finally the idea is to reach the summit and make a specific diagnosis. The other limitations are diseases with biopsied early or late in the course of the evolution of the disease may not reveal typical findings. And this is very often that happens in day-to-day practice because clinicians don't biopsy typical diseases because they can make the diagnosis clinically. If they were to biopsy that, more biopsies will show typical findings. But what they biopsy are those which they do not understand. And these generally show atypical findings and can be difficult to interpret. The other thing is new diseases as they come along may be missed because they have not been described and they may not fit into typical patterns. What are the advantages? Based on histological findings, a small group of diseases can be considered in the differential diagnosis. Combination of patterns and specific findings can be used to zero into the correct diagnosis. Now, I'll quickly go through this because this is very important when you actually practice dermatopathology or any part of pathology, I suppose. Sampling of tissue, and particularly in skin, it becomes very important. Sampling is very important. And that is the job of the clinician to biopsy the correct site. Processing has to be good because you can get a lot of artifacts. Communication is very important. The clinician has, in surgical pathology, especially with malignancies, it doesn't really matter. I mean, of course, clinical history is important, but then morphology is the king. Whereas here, you do need a lot of clinical pathological correlation. So good communication between clinician and pathologist is extremely important. Now, when we look at the slide, we also should know what is our capability of rendering a specific diagnosis because our reports have to be based. So what is our impact on diagnostic findings? Now, if you look at this, everybody agrees that this is an elephant. There's no doubt about it. So if this is what the clinician is seeing, and if this is what you are seeing, this is molluscum contagiosum. This is a hyperplastic follicular infundibulum, and these are all pink molluscum bodies, viral inclusion bodies, which whether you have the diagnosis or not clinically, you can make a definitive diagnosis histologically. So this is where you can be very specific about the diagnosis. Some people call it a full stop diagnosis, that you make a diagnosis, period. This is molluscum contagiosum, whatever be your clinical diagnosis. On the other hand, the clinician may see something like this, or you may see something like this, and you may not be able to give a definitive diagnosis. You still feel this is an elephant. Most of the things are there, but it could be something else. So you do need clinical correlation. Here, for example, looks very psoriasiform. So it's good to call it psoriasis, but there is some spongiosis. There is a well-formed granular layer. So this could also be a spongitic dermatitis. So is it psoriasis or is it an acral dermatitis? So here you do need good clinical diagnosis. Here you cannot make a full stop diagnosis. Here again, if you see spongiosis, so is this psoriasis or is it spongitic dermatitis? It could be either of them. The first one looked very much psoriasis. The second one looked more eczematous or spongitic. So this would be a common diagnosis. That is, you're not very sure. The pathologist is seeing this, is not very sure. It could be either of the two. You do need clinical correlation. When you see something like this, still could be an elephant, but you can't be very sure. This is a pustule, intraepidermal pustule. So this could be pustular psoriasis, but it could be any other pustule also. It could be the top of a folliculitis, which you're not seeing here. What it shows is a pustule. That's all. You can't make a definitive diagnosis here. And this is even less of definitive diagnosis because you have just a few neutrophils here. Clinically, the clinician wants pustular psoriasis. You can't make a definitive diagnosis here. So this is the limitation that one must keep in mind. So this was early pustular psoriasis. And then, of course, if you see something like this, you just can't make a diagnosis. And you need to report it that way. So this was just an introduction to how we make diagnosis for inflammatory skin diseases. Are there any questions on this?
No, sir. So far, no questions. We can go ahead with our cases.
Let me open the next one.
If you click on the right side, you can get the laser pointer options. Right side.
No, but
you can see, sir, the case one. Yeah,
you can see the case.
Yes, sir. We can see the slide here.
Okay. Then let the person who is doing the case start it.
So on the slope,
Yeah, go ahead.
on the slope, we can see that section shows hyperkeratosis with thickened epithelium, thickened epidermis showing rete ridges which are elongated, and we can see that the rete ridges are regular in size. Also, the dermis which appears below appears to be unremarkable, and we can see that the papillary dermis is projecting inside, in between the rete ridges. So moving on to higher power. On this power, we can see that we can see parakeratosis with again the rete ridges showing bulbous ends, and the papillary dermis is projecting in between the rete ridges with avascular lymphocytic infiltration, which is mild. Moving on to the higher power. So yes, you can see that there are some vessels in the papillary dermis which are surrounded by few lymphocytes, and also. So can we go on the previous slide, please? Yeah. Also, we can see that there is absence of granular stratum granulosum, which should be between the stratum corneum and spinosum, which appears to be absent, and also there is suprapapillary thinning, which we can see. Yes. Next slide, please. Next slide. On this slide, we can see that there are some neutrophilic abscesses, microabscesses, which is superficially present on the epidermis. So combining all the features, we can say that this is a psoriasiform reaction pattern.
So would you give a definitive diagnosis for this as psoriasis?
Yes, sir. If the clinical history correlates, we can give the diagnosis.
Okay. So this is very typical psoriasis. So here, I mean, I don't think you can have any other differential diagnosis here. So as she described, psoriasiform hyperplasia, which consists of this club-shaped rete, suprapapillary thinning, absence of granular layer, stratum corneum, which has a lot of parakeratosis and also neutrophils in it, and dilated tortuous capillaries, which go up to the lower part of the suprapapillary epidermis. There is a clinical sign here because of this known as Auspitz sign, wherein if you rub the surface of it, if you remove the scales, you will get pinpoint bleeding. The bleeding occurs because of these dilated capillaries which are located very close to the surface. And this is also something which is very classical for psoriasis, which is the beginning of a spongiform pustule, collection of neutrophils in the upper part of the spinous layer. And in the stratum corneum, if you see there are neutrophils, so you have flat parakeratosis and you have neutrophil. So this is very typical for psoriasis. So these are the findings, and this particular slide shows almost all of them. But psoriasiform, so this is classical psoriasis. So it's not very difficult to make to this one, but you may not get all the findings all the time. And you also have other diseases which give rise to the psoriasiform pattern. In a sense, it's fairly common and non-specific. So most diseases with psoriasiform epidermal changes have findings that are either diagnostic or have clues to the diagnosis. Chronic plaque psoriasis is the prototype of this reaction and serves as a comparator with other diseases that exhibit this pattern. So taking that as a prototype, you can develop this pattern further. These are all the epidermal changes that you get: elongated club-shaped ridges, suprapapillary thinning, increased mitotic figures in basal and suprabasal layers, because psoriasis is a hyperproliferative skin disease. The normal time taken for a germinative cell from the basal cell layer to be shed off as a stratum corneum is about 4 weeks. But in psoriasis, it happens within about 7 to 10 days. So you get a lot of mitotic figures. You get pallor of the upper spinous layers. You get a decreased granular layer. You have collection of neutrophils in the upper spinous layers known as spongiform pustule of Kogoch, and neutrophils in the stratum corneum, which used to be known as micro abscesses of Monroe. And then you have a thickened horny layer that has mounds of parakeratosis, which are arranged in vertical tiers and contain neutrophils. In the dermis, you have elongated dermal papillae, which house dilated and tortuous capillaries. You have perivascular lymphocytes and neutrophils. Upper dermal edema may be present, and there may be an increase in number of mast cells. So this is the typical dilated capillaries. So you can get variants of psoriasis. So what we described just now was for classical chronic plaque psoriasis. But psoriasis has many clinical variants. You can get the guttate and pustular variants. So guttate is a scatter of small lesions, usually follows streptococcal throat infection. And here, because it happens very rapidly, there will be an absence of psoriasiform hyperplasia. The granular layer may be only minimally diminished and spongiosis may be present. In acral psoriasis, that is psoriasis on the palms and soles, it's often spongiotic and may be mistaken for a spongiotic or a eczematous dermatitis. It again has a well-formed granular layer because the palms and the soles show a very thick granular layer. You can get many lymphocytes in the dermal papillae, and you might also get epidermotropic lymphocytes, which at times may simulate early mycosis fungoides. So, for example, here you do not have the typical psoriasiform hyperplasia, and also the granular layer is fairly well developed. But in the stratum corneum, you have a single mound, a conical mound of parakeratosis with neutrophils. This is very typical for psoriasis. So this is guttate psoriasis. The disease happens so rapidly that it doesn't give time for the psoriasiform hyperplasia to develop. And because it is rapidly happening, the granular layer too is well preserved. This is pustular psoriasis, where clinically you get pustules and not plaques. And here again, you do not have a psoriasiform hyperplasia, but you have a small collection of the spongiform pustule of Kogoch's form. It happens so rapidly that you do not even have time to get parakeratosis. So you have a normal stratum corneum, you have an intraepidermal pustule, a subcorneal pustule, and no psoriasiform hyperplasia. You get pallor here. So this is pustular psoriasis. So how do we approach psoriasiform reactions? You can get several etiologically unrelated diseases which show the psoriasiform pattern. The presence of psoriasiform epidermal hyperplasia is the first step in evaluation and is done at scanning magnification. So once you have determined that this shows psoriasiform hyperplasia, then you start looking at higher powers to recognize other specific and suggestive findings, and you can establish a differential diagnosis. These findings are then correlated with the clinical findings for a specific diagnosis. Now, several algorithms are available. I showed you one of them in most standard textbooks to arrive at the most likely diagnosis. So a host of diseases can give rise to the psoriasiform pattern. A group of them would be known as the papillosquamous diseases, which would include psoriasis, pityriasis rubra pilaris. Now here the specific pattern, the specific finding is checkerboard parakeratosis. Seborrheic dermatitis. Here the specific finding is parakeratosis at the lips of the follicular ostium. ILVEN, which is inflammatory linear verrucous epidermal nevus. Here the specific finding is mounds of layered parakeratosis, which alternate with orthokeratosis. Pityriasis rosea, especially the first herald patch, which is a large lesion. You get spongiosis, moving scale, and a lifted off scale. And long-standing spongiotic dermatitis or photodermatitis. So all these clinically would show scaly erythematous plaques. So clinically they may look very similar. Histologically they may show the psoriasiform pattern. So you look at the specific findings to make definitive diagnosis. For example, in pityriasis rubra pilaris, this is what is known as the checkerboard pattern. So if you see, you have parakeratosis, which is vertical and horizontal layer. So this is like a chessboard. So you have one here, one here, one here, or almost like a staircase, stepway, and no neutrophils. Psoriasis would almost always have neutrophils in the stratum corneum. Here, the granular layer will also be well formed. So with these findings, you can consider a differential diagnosis of pityriasis rubra pilaris. This is a hair follicle showing a little bit of spongiosis, and at the openings of the follicle, you see these scale crusts. So this is typical for seborrheic dermatitis. So shoulder parakeratosis at the lips of follicular infundibular ostium. If you see here, irregular psoriasiform, a normal stratum corneum, and here you have a broad column of parakeratosis, again broad column of parakeratosis. So alternating columns of parakeratosis. This is typical for ILVEN, inflammatory linear epidermal nevus. The broad columns of layered parakeratosis alternating with normal orthokeratotic stratum corneum. Then a whole group of diseases which are caused by external trauma, rubbing, scratching the disease. So lichen simplex chronicus, prurigo nodularis, acanthoma fissuratum, surface nodules, prayer nodules, all these histologically show psoriasiform hyperplasia, even lichen amyloidosis. So in lichen simplex chronicus and prurigo nodularis, you get psoriasiform hyperplasia with a uniformly thickened granular layer, a thick compact stratum corneum, no parakeratosis. In the dermis, you get thickened vertically oriented collagen bundles in the dermal papillae, which indicate the rubbing, variable dermal infiltrate, and dermal fibroplasia. And there is a hairy palm sign which has been described, that because of the thickened stratum corneum, it appears as if it is from the palm, but it is not from the palm, which can be made out by the fact that you have hair follicles. In the palm and toes, you have no hair follicles. So if you have skin which looks like that of the palm because of rubbing constantly and development of lichen simplex chronicus, finding of hair follicles suggests that this is lichen simplex chronicus. So this is an example of lichen simplex chronicus. This is an example of prurigo nodularis. The same patient. Here you have irregular hyperplasia of follicular epithelium. So therefore you get this irregular endophytic proliferation. Here you have more regular proliferation of the epidermis, which is psoriasiform. But unlike psoriasis, if you see, there is a very well-formed thick granular layer, and there is a thick compact stratum corneum without hardly any parakeratosis and a very sparse infiltrate. So though it looks psoriasis-like, this is lichen simplex chronicus. This is prurigo nodularis. Now, often these two conditions are superimposed on findings of other dermatosis like psoriasis, spongiatic dermatitis, etc. Then a whole group of deficiency dermatosis also give rise to psoriasiform hyperplasia. So you have acrodermatitis ectopathica, which is because of zinc deficiency, necrolytic migratory edema, which is because of glucagon secreting tumors, and pellagra of Hartnum disease. Here you get epidermal hyperplasia with variable spongiosis, ballooning of the upper spinous keratinocytes, thick crusts which reflect the clinical picture of crusted erosive lesions, and scattered apoptotic cells in the mid and upper spinal zone. Now, to take one such example, acrodermatitis ectopathica, which is an example of that. So if you see there is psoriasiform hyperplasia, there is a little ballooning, and individually necrotic or apoptotic keratinocytes. So if you see the upper part of the epidermis, there is pallor, there is ballooning. You can see the pale balloon keratinocytes and scattered dyskeratotic or apoptotic cells and broad scale crusts. So there is parakeratosis, there are neutrophils, and at times you can even get some plasma there. So here you have the apoptotic cells, balloon keratinocytes. So this is acrodermatitis ectopathica with psoriasiform hyperplasia. So the primary pattern is psoriasiform. The other group with psoriasiform hyperplasia and upper epidermal apoptotic cells is adult still disease, some drug reactions, and a condition called mechanic sign seen in dermatomyositis. In adult Still's disease, you get psoriasiform hyperplasia with scattered cells in the upper and mid spinal zone and neutrophils in the dermis. So at places there is this psoriasiform, and you see there are lots of these scattered dyskeratotic cells, not through the dermis, but more so in the upper epidermis, and neutrophils in the dermis. Then infections can give rise to psoriasiform hyperplasia, long-standing tinea, candidiasis, Norwegian scabies. See again psoriasiform, and these are this is of course a pH stain. You can see the dermal, you can see the separate hyphae, which are pus positive. So this is dermatophytosis or tinea. Again psoriasiform with a very thick stratum corneum, and in the stratum corneum you have these mites. These are scabies mites. So Norwegian scabies. So psoriasis-like lesions can be seen in a variety of diseases. You need to go to higher power, look at the specific findings, and then come to diagnosis. Then you can get a combination psoriasiform lichenoid. If you have lymphocytes, this is the differential diagnosis. If you have plasma cells, you have acrodermatitis. This you don't see in India so much. And if you have plasma cells, you think of secondary symptoms. So again, psoriasiform, a little bit of a interstitial and lichenoid infiltrate, lots of cells which are lymphocytes. Some of them are large within the epidermis without much spongiosis, well-formed granular layer, and thin parakeratosis. Another example where you have psoriasiform, a lichenoid, lymphocytic infiltrate, lots of melanophages, and lots of lymphocytes, haloid lymphocytes all along the basal layer, the so-called tagging of lymphocytes. So this is patch stage mycosis formitis. Another example where you get psoriasiform hyperplasia, broad parakeratosis, lichenoid infiltrate, and atypical cells, Bowen's disease. So all these can give rise to psoriasis-like cases. So the take-home message would be psoriasiform epidermal hyperplasia is a very common reaction pattern seen in a diverse list of diseases. The differential diagnosis, the different diseases can be differentiated by subtle epidermal findings that are clues. In some diseases, the dermal infiltrate is the predominant pathology. And of course, finally, clinical correlation is important.
So before we go on to the case 2, here there is just one question. How do we identify melanocytes in the basal layer?
Melanocytes are identified as cells which hang a little below the level of the basal cells and have clear space surrounding the nucleus. So if we come across, I'll show you melanocytes as we see them.
Okay,
But you can see them as cells with central nucleus and clear halo surrounding them at the dermoepidermal junction in the basal layer.
okay, thank you.
How are we doing for time?
Sir, we are fine. Perfect. No worries, sir.
No, not a question of worry. We could continue it next time. That is why.
No, sir, we can continue right
You
now.
feel that the time is okay.
No, yes, sir, we are perfect. We can continue right now. If there is anything,
Okay.
we'll let you know. We can go on, sir.
Right. So let's do the second case.
Hello, sir. Hello,
Yeah.
Yeah,
sir. Section.
Hello.
Can I say? Can I say?
Yeah, go ahead.
yes, Sandhya, go on.
Yes, ma'am. Sections from the skin biopsy shows in the low power it is hyperkeratotic, focal parakeratosis, acanthotic, stratified squamous epithelium. We can appreciate here mild spongiosis, and there is intraepidermal vesicles. You can see here, sir, filled with some homogeneous material, maybe inflammatory cells or acantholytic cells. And the superficial dermis shows perivascular inflammatory cell infiltration, and the deeper dermis shows perivascular and periadnexial inflammatory cell infiltration. Next slide, sir. In this slide, we can appreciate the parakeratosis, and there is a hypergranulosis. The granular layer is thickened, and the vesicles are mostly subcorneal vesicles. 2 vesicles are subcorneal vesicles, and 1 is intraepidermal, most probably suprabasal. Here, this vesicle granular layer is disrupted in this vesicle, which is on the left side, maybe probably due to the itching. and there is mild spongiotic and acantholysis also can be appreciated. So on superficial dermis, we can appreciate the mixed inflammatory cell infiltration, which is perivascular mixed inflammatory cell infiltration. Next slide, sir. Here we can appreciate the hypergranulosis more nicely, and there is the vesicles are filled with the mononuclear inflammatory cells, or it may be acantholytic cells, and there is lymphocytosis, exostosis in the epidermis. We can appreciate here, sir.
Okay. So what was the diagnosis?
So we can go for the approach based on the vesicles, whether the vesicles are intraepidermal or below the epidermis. So here the vesicles are intraepidermal. We can find them as a subcorneal vesicle. So the probable diagnosis, I have some DDs, sir. The one of this is bullous impetigo, which is subcorneal. We can find the subcorneal vesicles. In addition to that, the subcorneal vesicles may be filled with the bacteria or neutrophil infiltration. And there is in bullous impetigo, we can appreciate spongiosis and acantholysis also. And the second DD, we can go for subcorneal pustular dermatosis, which we can see in addition to the neutrophils, we can see the acantholytic cells also, sir. And the third one, we can appreciate in subcorneal pustular dermatosis, we can appreciate the psoriasiform pattern with elongated gritty ridges. And the third probable diagnosis can be pemphigus foliaceus, which are pemphigus foliaceus, sir. There will be subcorneal cleft. Here also there is one corneal cleft between the stratum corneum and the stratum granulosa, sir. So there may be dyskeratosis cell, and the fourth one can be DD can be Palmar dyshydrotic dermatosis, and next one can be spongiotic dermatosis. In spongiotic dermatosis, there will be spongiosis we can appreciate in the epidermis, sir. The bulla is intraepidermal bulla, we can see in spongiotic dermatosis. So these are my DDs, sir.
Very good. So what we'll do is we'll just turn your DDs upside down and start with the spongiotic first, because this is spongiotic dermatitis. Now, why is it not the first few that you said? First of all, let's look at it. So there is psoriasiform hyperplasia here, irregular, of course. There is, as you mark, there is a well-formed granular layer at places. Now, all these are actually intraepidermal. If you take this, for example, this is right within the spinous zone. And as you saw rightly, there's a lot of spongiosis here and exocytosis of lymphocytes. There are no neutrophils here. Call it a pustule. So if you're thinking of impetigo or subcorneal pustular dermatosis, you must have neutrophils as the predominant cell. Here, there are hardly any neutrophils. In fact, I don't really see any neutrophils here. What you see are mainly a few lymphocytes and the primary pattern. So here, if you see, there are two patterns. There is an intraepidermal vesicular and a spongiotic. So you can follow it either ways. You can take it as an intraepidermal vesicular dermatitis with spongiosis, without eosinophils, without neutrophils, and there are no acantholytic cells here really. Most of these are lymphocytes, and there is plasma. So if you see this is entirely within the epidermis. This is spongiosis, and these are small areas of parakeratosis. So this is a spongiotic dermatitis. So the best diagnosis here would be spongiotic. As you said, it could either be an dyshydrotic eczema, which occurs on the palms or soles. It could be a acute or a subacute eczematous dermatitis. So you could have atopic dermatitis, you could have nummular eczema, you could have allergic contact dermatitis. So the best diagnosis here would be spongiotic dermatitis. And what is spongiosis? It is intercellular edema, which leads to separation of spinous keratinocytes. It may lead to breakage of intercellular bridges and then form intraepidermal clefts and vesicles. Primarily, this is within the spinous zone. It is intraspinous vesiculation. And it could break open. Like here, for example, it is broken open into the stratum corneum. All this fluid will go up and form a crust over it. And therefore, clinically, these will look moist or this will look wet. And they look eczematous in clinical terms. So spongiosis may be the consequence of any inflammation in the skin. When we talk about spongiotic dermatitis, we are basically talking about those conditions in which spongiosis is the predominant pathological finding. So all the eczemas, pityriasis rosea, erythema annularis centrifugum, and some drug reactions, not all, but some drug reactions. Spongiosis can also be the result of dermal inflammatory processes. And spongiosis, but then in that case, you can make a diagnosis based on whatever the dermal problems are. So when you talk about spongiotic dermatitis, the primary pathology is within the epidermis. And spongiosis can lead to other consequences like acantholysis, but you can very rarely see acantholytics in spongiotic conditions. So histological, yeah, any questions?
So that same question, there was one that if there are intradermal vesicle contains neutrophils, how do we differentiate pustule and pemphigus? If we are going to cover it in the subsequent the cases, then maybe we can.
Some slides afterwards. We'll talk about it later.
Okay, okay, sir.
So what are the histological findings? In the epidermis, in mild spongiosis, you get pallor of the intercellular region, separation of spinous keratinocytes from one another. That is, you get visible intercellular bridges. You get exocytosis of inflammatory cells, which are mainly lymphocytes, but you can also get eosinophils and neutrophils, in which case you call it eosinophilic spongiosis and neutrophilic spongiosis. And then you have a totally different set of differential diagnoses. Parakeratosis is there. It's not really rare, but it's not as common as in psoriasis. In well-developed spongiosis, you can get clefts and vesicles, which is what we have seen in this case. Vesicles might rupture into the stratum corneum and then show parakeratosis. And in the late stage, spongiosis may be very minimal. You get hyperplasia, which will be psoriasiform, and you get parakeratosis and scale crushes. In the dermis, you can get a very dense lymphocytic infiltrate. You may get other inflammatory cells, especially eosinophils, and you can get post-inflammatory cells in the form of melanophages, dermal fibroplasia, and fibrosis. So the typical spongiotic dermatitis are these: allergic contact dermatitis, nummular dermatitis, ED eruptions, and dyseprotic eczema. Now, all these can look very similar, so you can't give a specific diagnosis of which condition it is. You can only say spongiotic dermatitis, and then clinically you'll have to correlate and see in which of these categories it fits. But you can also get spongiosis, which could be focal and localized to adnexal structures. So if you get predominantly follicular spongiosis, that people consider atopic dermatitis, follicular eczema, which is again a variant of atopic dermatitis, pityriasis alba, which is again a variant of atopic dermatitis, seborrheic dermatitis, and a condition known as infundibular follicular. If you have spongiosis affecting the eccrine sweat ducts, you consider miliaria rubra. And if you get only focal spongiosis, mild, you consider pityriasis rosea and erythema annularis emptyphyllum, which both of them look very similar clinically and histologically. So here, if you see, you have spongiosis, but it's focal. It's restricted to 3 follicles. So this is follicular spongiosis. You have spongiosis of the infundibulum here and of the overlying epidermis. So this is follicular spongiosis, and very typically seen in atopic dermatitis, can also be seen in seborrheic dermatitis. On the other hand, you have mild spongiosis, which is involving, this is a dermal part of the sweat duct, which is coming into the epidermis, and this is what is called the acrosyringe effect, the epidermal part of the sweat duct. And there is spongiosis here, surrounded by surmounted by a small parakeratotic crust. So this is miliarial spongiosis. Here you can see the spongiosis, mild spongiosis, exocytosis of few lymphocytes, and parakeratosis. So this is the acrosyringe. This is the sweat duct as it moves through the epidermis. So this is miliaria rubra. And you can get focal spongiotic dermatitis, as you see in pityriasis rosea. So here you get acanthosis. You don't get psoriasiform, but it's acanthotic, superficial perivascular lymphocytic infiltrate, and just a single focus of spongiosis here. If you see mild spongiosis, where you can see there's no vesicle, but the cells are separated from one another. There are a few lymphocytes. Another example where you have 2 foci of spongiosis. Here there are more lymphocytes. And these are also known as pseudoporphyria collections, as against the porphyria collections that you get in mycosis fungoides or in Sézary syndrome. So this is pityriasis rosea or focal spongiosis. Then other conditions where you can get spongiotic is eosinophilic sponge. That is when you get spongiosis with eosinophils. That you can get in pemphigoid, pemphigus vulgaris, insect bite. So wherever you have diseases with a lot of eosinophils, you can get spongiosis with a lot of eosinophils in the epidermis. The same thing will happen with neutrophils. This typically occurs in pemphigus foliaceus and IgA and in some drug eruptions. So how would you approach this? If you have spongiotic dermatitis with only spongiosis, and if you have mainly lymphocytes, these would be the differential diagnosis. Allergic contact dermatitis, nummular eczema, ED eruptions, dyseprotic eczema, photoallergic dermatitis, early polymorphous light eruptions, even dermatophytosis, that's tinea, in which case you need to demonstrate the tinea in the stratum corneum, seborrheic dermatitis, and pityriasis rosea. If you have lymphocytes plus eosinophils, the differential diagnosis still includes eczemas, but now it also includes bullous pemphigoid, pemphigus vulgaris, incontinentia pigmenti, insect bite reactions, drug eruptions, and a condition known as toxic erythema of infancy. This occurs only in infants. And if you have neutrophils, then you start thinking in terms of IgA, pemphigus, and acral psoriasis. And then if you have spongiotic dermatitis with other patterns, so if you have psoriasiform, then long-standing eczemas, seborrheic dermatitis is a condition known as non-bullous congenital ectasiform erythroderma. Forget that. Even mycosis fungoides can show this. So spongiotic lichenoid can be seen in lichen striatus and mycosis fungoides, and spongiotic psoriasiform lichen is seen in these 2 conditions. So this was spongiotic dermatitis. Any questions on this?
No, sir, we can move on to the next case.
So who's describing this?
Sir, in this section of skin, we can see epidermis and dermis. The epidermis shows hyperkeratosis and parakeratosis. Also, in the subcorneal part, there is we can see a blister which is eosinophilic, and in the superficial dermis, we can see that there is a perivascular infiltration. So, can you go on the next slide, please? So in this, the epidermis, we can see that there is ballooning degeneration of the keratinocytes. That is, there is intracytoplasmic edema, and the nucleus is pushed towards the periphery. So maybe move on to the next slide. In this slide, we can see that there is in the previous slide, we could also see acantholysis. In this, we can see that the cytoplasm is eosinophilic. Also, we can see some intranuclear inclusion bodies. And in the previous slide, sir, if you can go to the previous slide, we can see that in the superficial dermis, there is mononuclear inflammation around the vessels, mostly of lymphocytes, and also some neutrophils also we can see. So, sir, this may be the case of herpetic dermatitis.
Good. So, there is psoriasiform hyperplasia, and as you rightly pointed out, there is this very large area of pallor here, a little bit of pallor over here, so which at higher power you said that this was ballooning, and there is almost a confluent crust over here. So you can see this crusting and parakeratosis here. There are neutrophils. There is no vesicle as such here. There is no intraepidermal vesicle formation. The primary pattern here is that of ballooning. There is psoriasiform or irregular psoriasiform hyperplasia, and there is ballooning, which you rightly pointed out. So there is ballooning. There are a few necrotic keratinocytes or apoptotic keratinocytes, if you see here, and a scale crust. So this actually is a case of leukogonoma associated necrotic migratory erythema. This is very difficult to diagnose. I basically kept it not for the diagnosis, but just to demonstrate what ballooning looks like. And in this particular case, this ballooning was the clue which made us make this diagnosis, of course, in concert with the clinical picture. So when you get ballooning changes of epidermis, you get large, it's intracellular edema. Unlike spongiosis, where it is intercellular edema, you get large keratinocytes with pale cytoplasm. You can get disruption of the cell membrane, giving rise to reticular degeneration and formation of multilocular blisters. Nuclear changes can be variable. So in most cases, like in this case, actually, you had small pycnotic nuclei due to effects of intracellular edema in most conditions. However, when you have infections like herpes, you get large nuclei because you start getting viral cytopathic effects. So when you have an infection of herpes, you get large nuclei with nuclear inclusions. Ballooning often involves the upper and the mid spinous layers with the formation of intraepidermal blister typically, but sometimes this blister, like in the previous case, we saw spongiotic vesicles opening onto the surface of the stratum corneum. Here, ballooning usually causes the blister to open into the dermis. So you can get intraepidermal and sometimes intra plus epidermal blisters. And so what are the consequences of ballooning? You can get acantholysis, which is typically what happens in herpes. You can get reticular alteration of the epidermis, that is multilocular blister formation, which typically occurs in insect bite reactions or in irritant dermatitis. You can get intraepidermal blister formation, subepidermal blister formation at times, and sometimes if the ballooning is very severe, it causes complete necrosis of the epidermis. And this is typically seen in Stevens-Johnson syndrome or toxic epidermal necrolysis. So what are the conditions that are associated with ballooning of epidermis? You can have external factors which cause ballooning, and the commonest is irritant and caustic damage. So if you have exposure to, say, mild acids, alkalis especially, caustics, that can cause ballooning. Phototoxic damage, vesiculants and chemicals like cantharidin, insect bites, blister beetle effects, physical excoriation, that even excoriation can give rise to ballooning, and effects of freezing. Freezing also causes ballooning because it causes freezing of the liquid within the cell, which then causes the cell to undergo ballooning. And you can get internal factors which give rise to ballooning. So mechanical factors, friction blisters. So when you walk a lot or you have shoes which are too tight and you walk more than what you are used to, you start getting blisters on the. Now, if you do a biopsy, what you will see is an intraepidermal blister because of ballooning. Then you have genetic diseases like epidermolytic hyperkeratosis, in which ballooning of the spinous keratinocytes gives rise to intraepidermal blisters. Deficiency dermatosis. This is where this particular case fits in. This is necrolytic migratory erythema, pellagra, and acrodermatitis entropathica. Also show ballooning. Now, in the previous pattern of psoriasiform, I also showed you acrodermatitis entropathica. And acrodermatitis entropathica also comes here. So this is the thing, that the same disease can come in different patterns. Depends on which factor or which sign or which finding you are following, or which finding is more prominent there. Then interface diseases, erythema multiforme, pleva, Stevens-Johnson syndrome, they will show ballooning. And of course, viral diseases, HSV or hand, foot and mouth disease, all of them show ballooning. So deficiency dermatosis, this particular case is a glucogonoma syndrome. This is what it looked like. This was the patient who had this extensive necrolytic skin patches, loss of weight, diabetes, and he had a glucogonoma, which when it was removed, all this cleared within a week. Then herpes and other viral infections also give ballooning. So herpes simplex virus, varicella zoster, vaccinia, variola, hand, foot, mouth, all of these give rise to intraepidermal ballooning and blister formation. They can also give rise to acantholysis and multinucleate giant cell formation. So clinically, they present as vesicular eruptions with surrounding erythematous halo and resolve with crusting. Scarring can be severe in varicella zoster and variola. Okay, so that was ballooning. Any questions on that?
So I have a question.
Yeah.
Yes. So as we saw that if we can have ballooning in most of the viral infections, how can we be able to distinguish them?
You can distinguish a few of them. For example, herpes virus can be distinguished because they have very specific cytopathic effects, which consists of large nuclei. Then you have margination of the nuclear membrane, and you get a steel gray nucleoplasm, and you get acantholytic cells with multinucleated giant cells, so-called Zang cells. So that is very typical for herpes virus. The other viruses are not always easily recognizable because they do not have that specific findings. But all of them, like ORF, hand, foot and mouth disease, all of them give rise to intraepidermal blistering. And that blistering primarily is because of ballooning. So somewhere, and again, it depends on when the biopsy has been taken. If it is taken very early in the disease, you would get ballooning. If it is taken in a well-developed vesicle, you will get an intraepidermal blister. And if it is taken in a very late lesion, you will get just a crust formation. So timing the biopsy is also very important. But to answer your question, in herpes, you have specific cytopathic effects, which you can make a diagnosis with.
So I think similar question. How do you differentiate balloon keratinocytes and viral affected coilocytes?
They're the same.
Yeah, same thing.
Affected coilocytes are balloon cells.
Yeah. And sir, how do you differentiate between coilocyte and pseudocoilocytes?
I don't know. I don't know what is a pseudocoilocyte. Well, we do see in the skin, we see a lot of artifacts. If you refer to pseudocoilocytes by that, because we don't generally use that term. But like you get coilocytes. Basically, what is a coilocyte? If somebody could tell me.
Doreen, you could.
Yeah, yes, sir. A coilocyte is simply a cell which I cannot explain it.
Okay, anybody?
How today?
Sir, coilocytic change means there will be nuclear atypia surrounded by perinuclear halo, sir. It may be due to the HPV related associate change.
Right. So what you have is you have a central nucleus, which usually shows some change. Either there is folding or there is irregular appearance of that, and there could also be a little atypia or hyperchromasia surrounded by a perinuclear clear space. And this is very typically seen in HPV infection, particularly on mucous membrane. So HPV on mucous membrane, that is condyloma acuminata. Coilocytes are seen in plenty. In other HPVs, you may not see this typical coilocytic cells. What you see are a lot of viral inclusions. For example, in plantar warts or verruca vulgaris, you can see a lot of basophilic viral inclusions within the nuclei. Now, pseudocoilocytes are actually artifacts because in the epidermis, because of processing, sometimes you do get these perinuclear clear spaces. But there the nucleus is not affected like you get in coilocytes. So for making a diagnosis of coilocytes, you have to have nuclear changes.
Okay, so thank you. We can move on to the next one.
You want to stop here? What is the time now?
Sir, it is 8:30. Sir, we can continue.
No, let's stop here because the rest of the cases we don't have too much of discussion. We'll only have description and we'll discuss the individual cases. So we'll keep it for the next time because we have about 8 cases next time and another 2 or 3 cases from this. So that's how we can fit it in next time's thing.
Okay, sir. If you feel that we will be from case 4 onwards, we will be including in the
next time we'll straight away start from case 4. There won't be any talk. So we'll just discuss each one of the case.
Okay.
That otherwise if you do all the cases today, next time we may probably finish much earlier.
Okay, sir. Fine, as you say, sir. We can do that. Then we will share these cases with our students for the next batch, and maybe they can have a look at these cases.
Sure.
Okay. So I think with that, sir, I think we have already also covered all the questions related to the topic as we were taking the cases. So I don't think we have any more questions.
Okay.
So you can stop sharing the. With that, I think, sir, we would really like to thank you for making this topic so, putting it across in such a simplified manner. And we've already covered such a large spectrum. So I think students were also busy absorbing all the information and looking at those lovely images. So we would really like to thank you. So we will be having another session for this on Wednesday. We will continue this session. So please do join us. And thank you all the students. So we just have one more announcement to make. Komal, you can go ahead. Okay, I think... So thank you so much, everyone. Please do join us for a talk tomorrow again at 7 o'clock and again for the skin biopsy session on Wednesday. Thank you, everyone. Thank you. Good night.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, sir.